Welcome back to the deep dive. You asked us for it. A really deep look into neuraxial procedures. We're talking lumbar punctures, epidurals, getting that professional level grasp on the spinal canal's anatomy.
Yeah, it's about mastering the technical side, too. These aren't just routine procedures. They demand precision.
Right. This isn't just about theory. It's about understanding those critical millimeters in the OR that make all the difference between success and, well, a serious problem.
Absolutely. Things like epidurals and spinals, they're everywhere in clinical practice. Think obstetrics, pain management.
Lower limb surgery, abdominal cases.
Exactly. But just because they're common doesn't mean they're simple. The anatomy is complex, and that's what we really need to unpack today.
We need to get into the layers, the fluids, the structures.
Yeah.
Understand why the technique has to be so meticulous.
Precisely. It's non-negotiable if you want safe outcomes.
Okay, so let's lay out the core procedures we're aiming to master today.
Right.
First up, epidural injections.
Right. These are probably the most widely used. You see them a lot in labor analgesia, obviously.
And for things like radiculitis, right, that nerve root pain.
Yeah, treating that inflammation. Then number 2 is epidural catheterization.
So this is the continuous approach.
Exactly. You place a catheter, allows for ongoing administration of anesthetic. Think PCEA.
PCEA.
Patient-controlled epidural analgesia. Gives the patient some control over their pain relief, within safe limits, of course. Very common post-op or during labor.
Got it. And the third one, this sounds like the high-stakes one, lumbar puncture or a spinal.
It is. In terms of precision, it's a single shot directly into the subarachnoid space.
So right into the CSF.
Correct. Because you're putting the drug right where the nerves are bathed in that fluid, you need a much, much smaller dose.
Which means toxicity is less of a worry systemically.
Generally, yes. But the flip side is your placement has to be absolutely spot on. There's very little room for error.
Okay, let's start building that mental map. Before we even think about a needle, we need to understand the container, the boundaries. What are we dealing with structurally?
Right. So the outermost structure, the bony part, that's the vertebral canal. It's the protective housing for everything inside.
And the first sort of functional space we hit inside that.
That would be the epidural space. And importantly, it's a potential space.
Potential meaning. It's not really open until you put something in it.
Pretty much. It exists between the bone and the next layer, the dura mater, but it's normally collapsed, filled mostly with fat and veins. It's outside the dura.
Okay, outside the dura. And what defines its limits? Where does it start and end?
Superiorly, it goes up to the foramen magnum, the big hole at the base of the skull. It actually fuses there, which is good.
Why is that good?
It stops anything you inject epidurally from easily traveling up into the brain. That's a crucial safety feature.
Ah, okay. And the bottom end?
It extends down to the sacrococcygeal membrane, basically at the tailbone.
Okay, so we crossed that potential epidural space.
Yeah.
What's next?
You encountered the dura mater. This is the tough, fibrous outer wrapping of the spinal cord and nerve roots. Think of it like a strong sac.
The dural sac.
Exactly. It encloses the next layer, the arachnoid mater, and critically, the subarachnoid space, which contains the CSF and the spinal cord itself.
And does the dura go all the way down the spine?
The dural sac itself usually ends lower down than the spinal cord, typically around the S2 vertebral level in adults. The cord finishes higher up.
Right. We'll come back to that landmark. Now, between the dura and the next layer, the arachnoid, there's another potential space, isn't there? The subdural space. And you hear warnings about this one?
Yes, you do, and for very good reason. This is another one of those potential spaces, but it's clinically hazardous if you accidentally inject into it.
Why is it so bad? What's the key distinction we need to master here?
The absolute critical point is the subdural space does not communicate with the CSF-filled subarachnoid space. They are separate.
Okay, so if you put drug in there.
If you mistakenly place a catheter or inject a significant volume subdurally, a couple of bad things can happen. One, the drug, often in high concentration intended for the epidural space, can have direct toxic effects on the nearby neural tissue. And two, the volume itself can compress the delicate blood vessels supplying the spinal cord. That can lead to ischemia, lack of blood flow, and potentially permanent neurological damage. You're basically inflating a space that shouldn't be inflated.
Not good. So the goal for a spinal anesthetic is to get past the dura, past the subdural space.
and into the subarachnoid space.
And this one is a real space.
Yes, this is an actual existing space. It's filled with cerebrospinal fluid, CSF, and it's continuous with the spaces around the brain. It's where the spinal cord and nerve roots float, essentially.
Okay, let's spend a minute on the CSF itself. It's obviously vital. What are the key things clinicians need to know about it? Its dynamics.
Right, the hydrodynamics are important. CSF is primarily made in the ventricles of the brain by specialized tissue called the choroid plexus.
Yeah, where does it go? How does it get absorbed?
It circulates all around the brain and spinal cord, providing cushioning and nutrients, removing waste. Then it's mainly absorbed back into the bloodstream through structures called arachnoid granulations, which project into the big venous sinuses in the head.
What about the volume? How much CSF does an adult actually have?
It's surprisingly little. The total volume is only about 150 millimeters on average.
It's not much at all.
No, especially when you consider how fast it's produced. The production rate is around 25 milliliters per hour.
Wow, so the whole volume gets replaced, what, every 6 hours or so?
Exactly. That high turnover is really important clinically. It impacts how quickly infections might spread or how quickly drugs are cleared from the CSF.
And for spinal anesthesia, you mentioned the physical properties are key, specifically gravity.
Yes, the specific gravity of CSF is crucial. It's normally very consistent, somewhere between 1.004 and 1.0006.
And why does that number matter so much?
Because the local anesthetics we use for spinal blocks are often designed to be either hyperbaric, meaning heavier than CSF, or hypobaric, lighter than CSF, or sometimes isobaric, the same density.
So you can control where the block sets up using positioning.
Precisely. If you use a hyperbaric solution and the patient is sitting up, the anesthetic will tend to sink downwards. If they're lying on their side, it'll pool on the dependent side. Clinicians use this deliberately, combined with patient positioning, to control the height and spread of the anesthetic block. You absolutely have to know the baricity of your drug and the patient's position.
That's a critical piece of mastery right there.
Yeah.
Okay, let's circle back to the epidural space. We said it's the target for epidurals. How much does its size vary?
It varies quite a bit depending on the spinal level. This is really important for dosing and technique. The posterior part of the space, where we usually aim, is actually widest up high, in the upper thoracic region.
How wide are we talking?
It can be up to about 7.5 millimeters there, but then it narrows significantly as you go down.
Where's the tightest spot?
Around the T11, T12 level, it can be as narrow as 4.1 millimeter there. That makes thoracic epidurals technically more challenging.
And in the lumbar region, where most are done.
It widens out again, typically ranging between 4 and 7 millimeters in the lumbar area.
So that variability means you can't just use the same dose everywhere.
Definitely not. A dose that works well in the lumbar spine might be too much or too little in the thoracic region. You have to account for that changing volume capacity.
Let's nail down the boundaries of the lumbar epidural space specifically. Say L1 down to S1. What defines it?
Okay, so the lumbar epidural space runs from the bottom edge of the L1 vertebra down to the top edge of S1. If you think about its walls.
Anteriorly, what's in front?
In front, you have the back of the vertebral bodies and the intervertebral discs, and importantly, the posterior longitudinal ligament, PLL.
Okay, the PLL, we should probably define that quickly.
Sure. The PLL is a strong band of fibrous tissue running vertically along the back of the vertebral bodies inside the vertebral canal. It forms the front wall of the epidural space and helps stabilize the spine.
Got it. What about the sides of the epidural space?
Laterally, the boundaries are the pedicles, those bony struts connecting the vertebral body to the back elements, and the intervertebral foramina.
The foramina, those are the holes where the spinal nerves exit.
Exactly, and this is a key point. The epidural space communicates with the paravertebral space through these foramina. That's how drugs can spread outwards to some extent.
Okay, and finally the posterior boundary. What's behind the space?
That's formed by the ligamenta flava.
Yeah.
The yellow ligaments connecting the laminae and the vertebral laminae themselves, the bony roof.
Right, and the absolutely crucial surface landmark for finding the right spot to go in.
The intercrystal line, this is fundamental. You palpate the highest points of the iliac crests on the patient's hips.
The top of the hip bones.
Right. Draw an imaginary line between them across the patient's back. In most adults, that line crosses the spine at the L4-5 interspace.
And that's the sweet spot because...
Because the spinal cord itself usually ends much higher, around L1 or L2 in adults. So going in at L4-5 gives you a significant safety margin, minimizing the risk of hitting the cord with the needle.
But you mentioned a difference in kids.
Yes, this is a vital point of developmental anatomy. In infants and very young children, the spinal cord and the dural sac end lower down relative to the vertebrae. So that same intercrystalline landmark often corresponds to the L5S1 level in an infant.
So using the adult landmark in a baby could be dangerous.
It could put the needle tip much closer to the end of the spinal cord, the conus medullaris. You have to adjust your landmarks based on age. That's part of achieving mastery, knowing how anatomy changes. Okay, so we know the boundaries. But connecting this to the bigger picture, you have to understand that the epidural space isn't empty. It's packed with stuff, and that stuff really matters.
Matters for how drugs work and how things can go wrong.
Precisely. It's a dynamic environment. Its contents dictate drug spread, absorption, and unfortunately, they can also provide pathways for serious problems like infection or hematomas.
So what's the main thing filling up this space?
By far, the dominant component is epidural fat, especially in the posterior part of the space, dorsally.
And it's not just filler, right? You said it's functional.
Absolutely not just filler. It serves several important functions. Mechanically, it acts as a cushion.
Cushioning what?
It buffers the pulsations of the dural sac. Remember, the CSF pressure changes slightly with every heartbeat and breath, causing the sac to move subtly. The fat pads that. It also protects the nerve roots running through the space and allows the dural sac to glide a bit during movements like bending forward or backward.
Okay, mechanical roles. What about from a drug perspective, the pharmacokinetic role?
This is absolutely critical for anesthesiologists and pain specialists. Epidural fat acts as a significant reservoir for lipophilic drugs.
Lipophilic meaning fat-loving, fat-soluble.
Exactly. Drugs like local anesthetics and opioids, which are often quite lipophilic, will partition into this fat when injected epidurally.
What effect does that have?
It slows down their absorption into the bloodstream, and importantly, it prolongs their duration of action locally near the nerve roots. The fat holds onto the drug, releasing it more slowly.
So does the amount of fat matter, like comparing a very thin patient to an obese patient?
Hugely. It fundamentally changes the drug kinetics. A patient who is cachectic, very underweight, might have very little epidural fat.
So the drug has nowhere to hide.
Right. It might get absorbed systemically faster, or you might see a faster onset, but shorter duration of block, maybe even a more intense block initially because there's less volume for it to distribute into locally. Conversely, in a very obese patient with abundant epidural fat,
The drug gets soaked up more.
potentially, yes. You might need a larger initial dose or find the onset is slower, but the duration might be longer. The clinician absolutely has to consider the patient's body habitus and how it affects that epidural fat volume and dosing. It's not one size fits all.
Makes sense.
Okay.
Okay, fat is number one. What else is in there providing structure? You mentioned ligaments earlier.
Yes, the Hoffman ligaments, sometimes called meningovertebral ligaments. These are fibrous bands mainly found in the anterior part of the epidural space.
What do?
They act like little tethers connecting the front surface of the dural sac to the posterior longitudinal ligament on the back of the vertebral bodies. Their main job seems to be anchoring the dural sac, keeping it stable.
Do they get in the way of injections?
They can influence drug spread. Because they run front to back, they can effectively divide the epidural space into compartments anterior, lateral, and posterior. If these ligaments are particularly prominent, which they tend to be more in the lower thoracic spine, they might contribute to an uneven or patchy block if the anesthetic doesn't spread uniformly around them.
Interesting. What about nerves within the epidural space itself? Is the dura sensitive?
Yes, particularly the anterior dura. It's quite richly innervated. It gets sensory input from branches of the spinal nerves called the dorsal rami, and also from the recurrent meningeal nerves, or sinovertebral nerves.
So if something irritates the front of the dura, like a hematoma,
Exactly. That's likely to cause significant back pain. The posterior dura, on the other hand, has much sparser innervation. That's partly why a careful posterior approach for the procedure itself might cause less localized pain during insertion.
okay, now, the really high-risk component you flagged earlier, the extensive valveless venous system. Why is this such a critical piece of anatomy to master?
Because it's the source of potentially devastating complications, mainly bleeding, and it's also a highway for spreading pathology like infection or cancer metastases.
So what's the main network called?
It's the internal vertebral venous plexus. Think of it as a network of veins running up and down inside the vertebral canal, mainly on the front and back walls. It's composed of sort of 4 main interconnected longitudinal vessels.
And these are the ones you might hit during the procedure. leading to a traumatic tap.
Precisely. If the needle nicks one of these veins, you get blood back, which complicates things. But the real danger comes from the tributaries that feed into this plexus. The base of vertebral veins, those are important. They come out horizontally from the spongy bone of the vertebral bodies themselves.
Draining the bone marrow.
Yes, draining the vertebral bodies, and they empty into this internal plexus. And the absolute key feature of this entire system, the plexus and the base of vertebral veins, is that they are valveless.
Valveless, meaning blood flow isn't directed one way, it just follows pressure gradients.
Exactly. There are no valves to stop blood flowing backwards, and this is where this systemic connection becomes critical.
How does it connect elsewhere?
This internal vertebral plexus has direct, wide-open connections with the deep pelvic veins draining the bladder, the prostate in men, the rectum.
So if pressure builds up in the abdomen.
Right. If the normal route for venous return via the inferior vena cava, IVC, is obstructed or has high pressure, think late pregnancy, a large abdominal tumor, even straining hard blood, gets shunted backwards from the pelvis up through these valveless veins and directly into the vertebral venous plexus.
It's like a safety bypass system for venous blood when the main highway is blocked.
It is. It's an anatomical adaptation. But the massive downside is that it provides a direct low-resistance pathway for anything nasty in the pelvis infection, cancer cells to travel straight to the spine.
Bypassing the filters like the liver and lungs.
Completely. This is the anatomical basis for why, for example, prostate cancer so frequently metastasizes to the vertebral bodies. It's a direct shot up Batson's plexus, as this venous system is sometimes called.
And clinically, for the procedure itself, when is the risk of hitting these veins highest?
The risk increases dramatically whenever this plexus is engorged or distended. The classic example is pregnancy. The gravid uterus compresses the IVC, shunting blood into the epidural veins, making them larger and more fragile.
Makes them easier to puncture.
Much easier. Same applies to patients with large intra-abdominal tumors or significant ascites. Anything that increases intra-abdominal pressure can distend these veins, significantly raising the risk of a traumatic tap, or worse, causing an epidural hematoma if a catheter damages a vein.
Okay, that's the venous system high risk. What about arteries in the epidural space? Are they a worry?
Fortunately, the arterial supply is generally less of a concern with a standard midline approach. The spinal arteries, which branch off sources like the iliolumbar arteries in the lumbar region, tend to run more laterally within the epidural space.
So a needle coming in right down the middle should miss them?
Typically, yes. The lateral position of the main arterial feeders is a bit of a built-in safety factor for the midline technique. It's not impossible to hit one, especially with a paramedian approach, but it's much less common than encountering the venous plexus.
All right, this is where the rubber meets the road, or maybe the needle meets the ligament. We know the anatomy now, but getting the needle into the epidural space safely relies heavily on feel, doesn't it? Haptic feedback.
It really does.
Yeah.
Experienced hands develop a distinct feel for the different layers. Let's trace that path for a standard midline approach.
Okay, step by step.
First, obviously, is skin and subcutaneous tissue. Usually minimal resistance, feels soft. Then you feel a slight increase in resistance as you engage the supraspinous ligament.
That's the one connecting the tips of the spinous processes you can feel in the back.
Exactly. It's relatively thin but firm. After that, you advance deeper into the interspinous ligament, which runs between the spinous processes. This feels tougher, more substantial.
Okay, skin, subcutaneous, supraspinous, interspinous. What's the critical next layer?
The ligamentum flavum. This is the key. It connects the laminae of adjacent vertebrae, and it feels very different. It's dense, thick, almost gritty or rubbery.
And recognizing that feeling is crucial.
Absolutely. That distinct, dense resistance signals that your needle tip is immediately posterior to the epidural space. This haptic recognition is probably the single most important skill for traditional epidural placement.
So what happens when you push through it?
As you apply steady, controlled forward pressure, the needle suddenly pops through the ligamentum flavum, and you feel a distinct loss of resistance. The needle enters the relatively low-pressure epidural space, filled with soft fat. That pop or give is the confirmation you're in.
What if you misinterpret that feel? What are the risks?
Well, if you stop too early, thinking the interspinous ligament was the flavum, you're too shallow. Your injection won't work, or the catheter won't thread properly.
And if you don't feel the pop and keep pushing?
That's the big danger. If you push too hard or aren't sensitive to the loss of resistance, you can go straight through the epidural space, puncture the dura and arachnoid mater, and end up in the subarachnoid space.
Resulting in an accidental spinal block. if you inject the epidural dose.
Yes, a potentially dangerously high spinal block because epidural doses are much larger. Or at the very least, causing a dural puncture, which can lead to a post-dural puncture headache. So feeling that flavum and the subsequent loss of resistance is paramount.
Now, the distance from skin to that space isn't fixed, is it?
Yeah.
What's the typical range and how does weight play into it?
No, it's quite variable. The average depth is typically somewhere between 3 and 6 centimeters. But, and this is a really important clinical correlation, that depth increases directly with body mass index, BMI.
So in heavier patients, it's deeper.
Significantly deeper. In someone who is morbidly obese, the skin-to-epidural depth can easily be 8, 10, even 12 centimeters or more. You need longer needles. And anticipating that depth is crucial for success and safety. You don't want to get lost.
Okay, so feeling the layers is key.
Mm-hmm.
But how do we confirm we're in the right spot? You mentioned lots of resistance. Let's talk about the technique itself.
Right. The loss of resistance LOR technique is the standard method. It relies on that pressure difference. The ligamentum flavum offers high resistance, while the epidural space has neutral or slightly negative pressure.
How do you actually do it?
You attach a special low-resistance syringe, often glass, sometimes plastic filled with either air or saline to the epidural needle once you think you're engaged in the interspinous ligament or flavum. Then you apply constant, steady pressure to the plunger as you slowly advance the needle.
And when the needle pops through the flavum,
The resistance disappears and the plunger suddenly gives way easily. You can inject the air or saline with virtually no effort. That's your confirmation.
you mentioned air or saline. Is there a preference? Are there risks associated with the medium itself?
There's ongoing debate, and pros and cons to both. Aurora to air often gives a very crisp, undeniable loss of resistance. Some clinicians feel it's easier to detect that endpoint.
But there's always a but.
But there are potential risks, although rare. Injecting air, especially if you accidentally puncture a vein, could theoretically cause an air embolism. There have also been rare reports linking large volumes of epidural air to complications like pneumocephalus, air in the head, or even neurological issues, possibly from air tracking along nerve roots or direct entry if there's an unnoticed dural puncture.
Okay, so air is maybe sharper feedback, but with some potential, albeit rare risks. What about lower to saline?
Saline is generally considered safer regarding embolic risk, and it has another advantage. The small amount of injected saline can help gently push aside the epidural fat and dura hydrodissection, which might make it easier to thread the epidural catheter afterwards.
What's the downside of saline?
The main drawback is that the saline you inject to find the space can then dilute the local anesthetic or opioid you subsequently inject for the block itself. This might potentially slow the onset time or slightly reduce the quality or density of the final block.
So the choice depends on the situation. Needle versus catheter. Risk factors.
Exactly. Mastery involves choosing the right technique for the specific patient and procedure. Some even use a combination, like finding the space with air, then confirming with saline.
Okay, haptics and LOR are the mainstays. But sometimes anatomy is tricky. Scoliosis, previous surgery, obesity. What role does imaging play in improving safety and accuracy?
Imaging is becoming increasingly important, both for planning and for real-time guidance in difficult cases. For pre-procedural assessment, MRI is the gold standard.
Which type of MRI?
T1 weighted sequences are particularly valuable. Why? Because fat shows up as bright white on T1 images. So a T1 MRI gives you a really clear picture of the epidural space, showing you how wide it is, whether there's any distortion from disc herniation or stenosis.
So if you see a nice, wide, bright epidural space on the pre-op MRI,
You can anticipate the procedure will likely be technically easier. If it looks narrow or distorted, to expect challenges and plan accordingly.
what about using imaging during the procedure?
Ultrasound is fantastic for predicting depth, especially in obese patients. You can scan the back beforehand, measure the distance from skin to the lamina or ligamentum flavum, and choose the right needle length. It's non-invasive and quick.
But for really tricky placements, or in sensitive areas like the neck or upper back.
Then you often need fluoroscopy, which is real-time X-ray. Using fluoroscopy, especially with contralateral oblique views, gives you unparalleled visualization of the needle relative to the bony structures.
How does that help with depth control?
For example, in the narrow thoracic or cervical spine, you can deliberately advance the needle until it just touches the lamina, the bony roof. That gives you a definite, safe depth marker. You know you haven't gone too deep. Then you can carefully redirect slightly and walk off the bone into the epidural space.
And fluoroscopy becomes even more critical because of that finding about the ligamentum flavum not always being complete, right? Especially higher up.
Absolutely. That statistic is sobering. Incomplete midline fusion of the ligamentum flavum might occur in up to 67% of people at the C6-7 and C7-T1 levels.
2/3 of the time, the doorstop ligament isn't fully there.
Essentially, yes. Relying purely on feel or LRR in those cases can be misleading. The needle might just pass through a gap without that expected resistance, potentially going straight towards the dura.
Wow. So fluoroscopy lets you see the bony landmarks, like the spinal laminar line, to confirm your needle tip position, regardless of what the ligament feels like.
Precisely. The spinal laminar line marks the junction of the spinous process, and the lamina, it represents the posterior border of the vertebral canal. Seeing your needle tip at or just anterior to that line on the image provides crucial confirmation of safe placement.
Can fluoroscopy help even if you're using LOR?
Yes. If you use LOR to air, that small bubble of air you inject is often visible on the fluoroscopy image, appearing as a dark spot in the epidural space. This can provide visual confirmation of successful entry, sometimes even without needing to inject contrast dye. It's particularly helpful in patients with osteoporosis, obesity, or unusual anatomy where landmarks are difficult.
So imaging isn't just for difficult cases anymore. It's becoming a key part of routine safety, especially pre-procedurally. What specific conditions should really trigger a pre-op MRI?
We can think of them as congenital or acquired. Congenital issues would include things like achondroplasia, a form of dwarfism where the canal can be narrow, significant congenital scoliosis, or spinal defects like spina bifida occulta.
And things that develop later in life, acquired problems.
Common acquired issues include significant ligamentum flavum hypertrophy, where the ligament thickens with age, making LOR very difficult. Also, severe foraminal stenosis, narrowing where the nerves exit, or large disc herniations can distort or compress the epidural space. Previous spinal surgery with scar tissue is another major one.
So the take-home message is, don't wait to struggle during the procedure. If there are red flags in the history or exam, get that preoperative MRI.
Exactly. Use the imaging to anticipate the challenges. Plan your approach. Maybe you need fluoroscopy, maybe a different inner space, maybe a paramedian technique, or even decide if the procedure is too risky for that patient, and an alternative anesthetic plan is needed. Proactive assessment is key to avoiding complications. Now, what's truly fascinating and where mastery really comes in is understanding the profound difference in effect you get just by moving that needle tip a tiny bit deeper. Epidural versus subarachnoid, it changes everything pharmacologically.
You mean in terms of the dose required? Let's really nail that down. How much local anesthetic does it take to block one spinal segment epidurally compared to spinally?
Okay, so in the epidural space, remember the drug has to diffuse across the dura and through fat to reach the nerve roots. It takes a fair bit of volume. Typically, you need about 1.5 to 2 milliliters of local anesthetic solution to block a single spinal segment.
1.5 to 2 milliliters per segment. Okay. Now, what if you go just through the dura into the subarachnoid space for a spinal?
The difference is dramatic. Because you're putting the drug directly into the CSF, bathing the nerves, you need far, far less. For a similar level of block, you might only need about 0.3 milliliters per segment.
Wow, that's like a 5-fold, maybe even 7-fold reduction in volume.
It is, and that has huge implications for safety, particularly systemic toxicity.
How so?
Because the doses used for spinal anesthesia are so small, the risk of the local anesthetic reaching toxic levels in the bloodstream is extremely low. It's one of the major advantages of the technique for surgery on the lower body. Minimal drug, maximal effect right where you need it.
So spinals are great for surgical anesthesia due to low dose and low toxicity risk. What about epidurals needing the larger volumes? What are their primary clinical niches?
Epidurals really shine for continuous pain management. Because you can place a catheter, you can provide prolonged analgesia. Think PCEA, patient-controlled epidural analgesia during labor, or after major abdominal or thoracic surgery. It allows for hours or days of effective pain relief.
And epidurals are also used for non-anesthetic purposes, right, like steroid injections?
Yes, very commonly. Injecting corticosteroids into the epidural space is a mainstay treatment for radicular pain, nerve root pain like sciatica, caused by inflammation from things like disc herniation. The steroid delivers potent anti-inflammatory action right at the source of the problem.
Okay, let's switch focus to the effects of these blocks, particularly spinal anesthesia. When you induce a spinal, you're causing some major physiological changes. What's the primary immediate concern?
Cardiovascular effects, specifically hypotension, low blood pressure.
Why does that happen so reliably?
It's due to the sympathectomy. Spinal anesthesia blocks the sympathetic nerve fibers that control blood vessel tone. These fibers run from about T1 down to L2 in the spinal cord. Blocking them causes widespread vasodilation, especially of the veins, the capacitance vessels.
So the tank suddenly gets bigger.
Exactly. Blood pools in the dilated veins, venous return to the heart decreases, peripheral vascular resistance drops, and blood pressure falls, sometimes quite dramatically and quickly.
Which means you absolutely must be prepared to treat it immediately.
Non-negotiable. You need IV access established, of IV fluids ready to give as a bolus, and vasopressor drugs like phenylephrine or ephedrine drawn up and immediately available before you even start the block. Managing that expected hypotension is part of the standard procedure.
What happens if the block goes higher than intended? A high spinal?
The level of the block determines the severity of the side effects. If the block ascends to the T14 level, it can knock out the cardiac accelerator fibers.
Affecting the heart directly.
Yes. You can see significant bradycardia, slow heart rate, and even decreased myocardial contractility, weaker heartbeat.
And if it goes even higher, say up into the neck.
That's the most dangerous scenario. An extremely high block reaching the C2-3 level can paralyze the phrenic nerve, which controls the diaphragm, as well as the intercostal muscles needed for breathing. This leads to respiratory arrest. The patient stops breathing, causing rapid hypoxia and hypercarbia. It's a true anesthetic emergency requiring immediate airway management and ventilation.
Scary stuff. Let's talk about a more common, though still unpleasant, complication. The post-dural puncture headache, PDPH. What causes it, and how can we minimize the risk?
PDPH happens after the dura has been punctured, either intentionally during a spinal or accidentally during an epidural attempt. CSF leaks out through the hole faster than it can be replenished. This lowers the CSF pressure,
Causing the headache.
Yes. It's thought that the low pressure causes sagging of the brain and traction on pain-sensitive structures like blood vessels and meninges, leading to that characteristic positional headache, worse when upright, better when lying down.
How do we prevent it, or at least reduce the chances?
Two main strategies: needle size and needle shape. Firstly, use the smallest gauge needle feasible for the procedure. A 25 or 27 gauge spinal needle makes a much smaller hole than, say, a 22 gauge.
Makes sense. And needle shape.
This has been a major advance. Using pencil point shaped spinal needles like Whitaker or Sprott needles instead of the older sharp cutting edge Quinnet needles makes a big difference.
How do they work differently?
The pencil point design tends to separate or spread the dural fibers rather than cutting a clean hole through them. When the needle is removed, the fibers tend to close back together more effectively, reducing the size of the rent and significantly lowering the incidence of PDPH.
Good tip. Okay, finally, we need to touch on the rare but truly catastrophic complications. Epidural abscess and epidural hematoma.
Both are neurological emergencies requiring prompt diagnosis and treatment. An epidural hematoma bleeding into the epidural space typically presents with sudden, severe back pain that is unrelenting, followed relatively quickly by progressive neurological deficits, bilateral leg weakness, numbness, tingling, potentially bowel or bladder dysfunction. It's caused by the expanding blood clot compressing the spinal cord or cauda equina.
In diagnosis, how do we confirm it?
Clinical suspicion is high with that presentation, especially after a recent spinal procedure or in a patient on anticoagulants. But confirmation requires urgent MRI.
What does it look like on MRI? Does the appearance change over time?
Yes, the signal characteristics change. In the acute stage, first day or two, the hematoma typically appears as low signal intensity on T1 weighted images and high signal intensity on T2 weighted images. This specific appearance helps differentiate it from other things like tumors or chronic collections. Knowing these imaging features is vital for rapid diagnosis, often leading to emergency surgical decompression to prevent permanent paralysis.
And an epidural abscess. Similar presentation.
It can be similar back pain, fever, neurological deficits, but might evolve slightly more slowly than an acute hematoma. Diagnosis also relies on MRI, often with contrast enhancement, and treatment involves antibiotics and potentially surgical drainage. Both are devastating if missed.
Okay, given these potential risks, who absolutely should not get an epidural or spinal? What are the key contraindications?
There are several absolute contraindications. One is patient refusal, obviously. Medically, severe hypovolemia, like someone in shock, is a major one because they simply cannot tolerate the vasodilation and drop in blood pressure from the sympathectomy.
What else?
Any significant coagulation disturbance, whether due to medication like anticoagulants or a bleeding disorder. The risk of causing a catastrophic epidural hematoma is just too high.
Mhm.
Active bacteremia or sepsis is another absolute no-go. You risk seeding that infection directly into the central nervous system.
Any specific heart conditions?
Yes, severe stenotic valvular heart disease, particularly severe aortic stenosis. These patients have a fixed cardiac output and rely on high systemic vascular resistance. The sudden drop in resistance from a spinal or high epidural can be fatal.
And wasn't there a specific neurological condition where caution is advised?
Yes, patients with pre-existing multiple sclerosis, while not always an absolute contraindication, spinal anesthesia has been associated with worsening of MS symptoms in some cases. It requires careful consideration and discussion with the patient and neurologist.
Okay, so pulling this all together, what have we achieved in this deep dive? We've mapped the anatomy layer by layer from skin down to the CSF. We've traced the needle path, emphasizing the feel of ligaments like the flavum.
We've highlighted the critical differences between the epidural and subarachnoid spaces, not just location, but fluid dynamics, dosing requirements, the whole pharmacology.
And stress that mastery isn't just about feel. It's about knowing when to use imaging, understanding the risks like that valvulus venous plexus, and anticipating problems based on patient factors and anatomy.
Exactly. It's about recognizing why precision matters, understanding the function of epidural fat, the danger zones like the subdural space, the implications of CSF turnover. That deeper knowledge informs every decision, from needle choice to managing complications. It's about moving beyond just doing the procedure to truly understanding it.
It really is. And that point about the valvulus venous system, Batson's plexus,
Yeah.
it keeps coming back. That direct, unfiltered highway connecting the deep pelvic organs, prostate, bladder, rectum, straight up the spine.
A system designed for venous return under pressure, but inadvertently creating this perfect pathway for disease spread.
It really makes you wonder, doesn't it? Thinking about modern cancer care, how much does that invisible anatomical feature, the base of vertebral veins and the whole valvulus plexus, silently influence the patterns and probability of metastasis, especially from pelvic cancers? Are we fully accounting for this direct, low-resistance superhighway when we stage cancers and predict outcomes? It's a sobering anatomical reality.